ST elevation in LBBB and paced rhythms. Does it mean a STEMI, or is the LBBB just playing certain tricks on me? Let's decode this in 2 minutes. So why is LBBB confusing? In LBBB, the ventricular depolarization is abnormal. Normally, the septum depolarizes from left to right. In LBBB, the septum depolarizes from right to left. The LV activation is delayed and it's abnormal, and the QRS becomes wide, more than 120 milliseconds. And because repolarization follows depolarization direction, this leads to secondary STT changes. In LBBB, the rule is if the QRS is positive, the ST segment is normally slightly depressed. And when the QRS is negative, the ST segment is normally slightly elevated. This is called an appropriate discordance. The problem is that this normal discordant ST elevation can resemble an anterior ST segment elevation. So this is where the Sgarbossa criteria helps us. The Sgarbossa criteria was originally described by Dr. Elena Sgarbossa in 1996 to help clinicians diagnose acute myocardial infarction in patients with LBBB. It essentially has 3 components. The first one being an ST segment elevation of more than 1 millimeter in any lead, in any concordant lead. Okay, so an ST segment elevation of greater than 1 millimeter in any concordant lead. A concordant ST segment depression of more than 1 millimeter in V1 to V3, which suggests a posterior wall landmine. And a discordant ST segment elevation of greater than 5 millimeter. A concordant ST segment means that the ST segment and the QRS complex go in the same direction. And a discordant ST segment means the ST segment and the QRS complex go in opposite directions. So the essential 3 components of the Sgarbossa criteria were that in the concordant segments, there should be a concordant ST segment elevation of more than 1 millimeter in any lead. And that's the most specific of all the 3 components. There should be a concordant ST segment depression of more than 1 millimeter in leads V1 to V3. This suggests a posterior wall MI. And a discordant ST segment elevation of greater than 5 millimeter. So that is the least specific of all the 3 components. But this criteria had a very low sensitivity, meaning there were a lot of false negatives to this. Hence, it was modified, and a modified Smith-Sgarbossa criteria came into picture, in which the first 2 components remain the same. Concordant ST segment elevation of more than 1 millimeter in any lead. And the second component, concordant ST segment depression of more than 1 millimeter in V1 to V3, remains the same. The third one has been changed. The ST to S ratio has to be greater than 0.5 in the discordant leads, meaning the ratio of ST segment elevation measured at the J point to the R or the S wave, whichever is more prominent in the discordant leads. So essentially, the ratio of the ST segment depression or elevation to the preceding R or S wave has to be greater than 0.25. So it essentially just compares the amplitude of the ST segment elevation or the depression from the J point to the preceding R wave or the S wave, whichever is more prominent. And if the difference in the amplitude is greater than 25%, then there is a very high likelihood that you're dealing with a occlusion MI or ST elevation MI. So applying the modified Sgarbossa criteria has helped in improving the sensitivity and specificity of diagnosing ST segment elevation in patients with a baseline LBBB. The modified Sgarbossa criteria provides a sensitivity of 62 to 84% and a very high specificity of 91 to 99% in diagnosing occlusion MIs in a baseline LBBB or a paced rhythm. The evidence that is there, so this is an article, diagnosis of ST segment elevation, myocardial infarction in the presence of left bundle branch block with the ST segment elevation to S wave ratio in the modified Sgarbossa rule. This was published in 2012, and this concluded that the replacement of the original Sgarbossa criteria by the modified Sgarbossa criteria greatly improved the diagnostic utility of the rule for STEMI, and unweighted rule using this criteria resulted in an excellent prediction for acute coronary occlusion. There's another article published in 2015 that also concluded that the modified Sgarbossa criteria was superior to the original criteria for identifying acute coronary occlusion in patients with LBBB. So what about a new LBBB? According to the latest ACC and the European guidelines, a new onset LBBB is not considered a STEMI equivalent. A new LBBB alone is not diagnostic of a STEMI. You should always combine it with the clinical picture, the troponins and the Sgarbossa criteria to diagnose a STEMI in patient with a new onset LBBB. According to the latest guidelines, a new LBBB is a sign of chronic cardiomyopathy, ischemic or non-ischemic, with a dilated or a hypertrophied myocardium, rather than a sign of an extensive acute infarction. So LBBB is a sign of a chronic cardiomyopathy, whether ischemic or non-ischemic, with a dilated or a hypertrophied myocardium, rather than a sign of an extensive acute infarction. So just remember, concordant changes are most specific. Applying the modified Sgarbossa criteria increases the sensitivity. A new LBBB is no longer equivalent to a STEMI. You should use your clinical judgment. So next time you see an ST elevation in an LBBB or a paced rhythm, don't panic. Apply the modified Sgarbossa criteria and let the ECG confess. Thank you.